So continuing with flaps, um, we talked about some flaps, and now the next one is osseous recontouring surgery. Its main goal is to eliminate periodontal pockets. The existing bony topography is changed to eliminate periodontal pockets. This surgery does not cure periodontal disease, but provides the patient the opportunity to and access to maintain their own periodontium and dentition with routine oral hygiene procedures. Before using osseous resection or recontouring to treat an infrabony defect, the dentist should consider these treatment alternatives: the maintenance with periodic root planning, bone grafts, reattachment, fill procedures, hemisection or root amputation. In some surgical procedures, it is necessary to leave interradicular bone exposed. This usually results in bone loss of no clinical consequence. Osseous resection surgery should not be done until etiologic factors that cause the osseous defects are arrested. Clinically detectable inflammation must be eliminated by SRP and by patients' ability to maintain optimal plate control. The most critical factor to determine if a tooth should be extracted or have surgery is the amount of attachment loss, the amount of apical migration of the epithelium attachment. Amount of attachment loss is the most important factor in determination of a prognosis of a tooth with periodontal disease. More accurate than probing depth, tooth mobility, and presence of furcation involvement is attachment loss. The primary objective of surgical flap procedures in treating periodontal disease is to provide access to root surfaces for debridement. The surgical flap goals to treat periodontal disease is to reduce or eliminate periodontal pockets, regrowth of alveolar bone, maintain biological width, and establish adequate soft tissue contours. Flap techniques vary with the goal sought, but the common goal of all flap procedures is to provide access for instrumentation. It allows the clinician to visualize the roots so calculus can be removed more completely. Without direct visualization provided by a flap, it is rare that a clinician can effectively root plane beyond 5 millimeters of probing depth or into root furcations of lesser depth. Flaps also make removal of granulomatous tissue from the region of the periodontal defect difficult. Again, flaps also make removal of granulomatous tissue from the region of the periodontal defect difficult. It is important to remove this since it contains epithelium and potential presence of bacterial infiltration. Again, without direct visualization provided by a flap, it is rare that the clinician can effectively root plane beyond 5 millimeters of probing depth or into root furcations of lesser depth. Flaps also make removal of granulomatous tissue from the region of the periodontal defect difficult. Now, if a patient fails to demonstrate adequate oral hygiene during initial therapy, surgery is contraindicated because after surgery, the incidence of disease recurrence is greater if oral hygiene remains poor. The best course of action is to continue to stress oral hygiene and maintain areas with scaling and root planning. Now, periodontal flap. Periodontal flap is a segment of marginal periodontal tissue that is surgically separated coronally from its underlying support and blood supply and attached apically by a pedicle of supporting vascular connective tissue. Flap procedures are the most common of all periodontal surgical techniques. Flaps should be uniformly thin and pliable. The flap base must be uniformly thin, around 2 millimeters thick, and all flap corners should be rounded. 4 rules of flap design. The flap base is wider than the free margin to allow sufficient blood circulation to the flap's free margin. Incision lines must not be placed over any bony defect to prevent delayed healing. 3. Incisions that traverse a bony eminence, like a canine, is avoided. The mucosa covering bony eminences is thin and healing is slow and may result in an ugly scar formation. Incisions made in tissues that harbor uncontrolled infection may cause rapid infection spread. Most periapical surgical procedures are performed only after anti-infective therapy is complete. All flap corners should be rounded since sharp points delay healing, and the healing will occur without complication if basic surgical principles are followed. Deep periodontal pockets are often treated by flap surgery. These causes often result in produced pocket depth by formation of a long junctional epithelium. These cases often result in reduced pocket depth by formation of a long longitudinal epithelium by soft tissue reattachment, even if there is no change in the position of the gingival margins. So the deep periodontal pockets are often treated by flap surgery. It doesn't mean that the positioning of the gingival margins goes up, but it does reduce the pocket depth by formation of a long junctional epithelium. The best indicator of success of a periodontal flap procedure is post-operative maintenance and plaque control by the patient. Now, we're going to see common flaps. The full thickness mucoperiosteal flap include the surface mucosa, epithelium, base membrane, connective tissue, lamina propria, and contiguous periosteum of the underlying alveolar bone. This flap involves reflecting all of the soft tissue and periosteum to expose the underlying bone. A full thickness flap is used where attached gingiva is thin. Apically and coronally positioned flaps are full thickness flaps. One of the example of a full thickness flap is a modified Whitman flap, in which a full thickness flap is a modification of a replaced flap. The modified Whitman flap is used in open flap debridement and regenerative periodontal procedures and is a mainstay of periodontal surgery on single rooted teeth in a flap surface on flap surfaces on molars affected by moderate pockets and infrabony pockets. The modified Whitman flap, its objectives are to gain access to underlying bone and root surfaces, reduced pocket depth by establishing a new attachment of a more coronal level, preserve an adequate zone of attached gingiva, and to provide an environment for healing by primary closure. So, modified Whitman flap. So the modified Whitman flap will have 6 steps. The first one is internal bevel incision, 0.5 to 1 millimeter away from gingival margin. The gingiva is reflected. Then the clavicular incision is made. Clavicular incision is made. Then interdental incision is made. The removal of the granulation tissue, tags and root surface is scaled, and the placement of the interrupted direct sutures. So the indications for modified Whitman flap is pocket bases located coronal to the mucogingival junction, where there is little or no thickening of marginal bone, when shallow to moderate pocket depths can be reduced, and when aesthetic is important, like anterior region. Now, the repositioned flaps include replaced flaps, modified Whitman flaps, and excisional new attachment procedures. They all heal by repair, by a long junctional epithelium and connective tissue adhesion or attachment, and are considered pocket reduction procedures. Pocket reduction is achievably maintained by gains in clinical attachment, mediated by repair. Now, this was all part of the full thickness mucoperiosteal flaps. Now, there's partial thickness periodontal flap. In this one, it includes only the mucosa epithelium and the layer of the underlying connective tissue. So it does not include periosteum. The mucosa is separated from the periosteum by sharp dissection. This is partial thickness. The alveolar bone is not exposed. These flaps are used to prepare recipient sites for free gingival grafts, or when a dehiscence or fenestration are present on a prominent tooth. A partial thickness flap is used when attached gingiva is thick. One determinant of how the flap will be raised, either a full or partial thickness, is the thickness or the amount of attached gingiva prior to surgery. Full thickness and partial thickness periodontal flaps can be displaced, but the palatal flaps cannot be displaced due to the absence of unattached gingiva on the palate. So there is no movement. Now, position flaps. The procedures in which the flaps coronal margins are advanced, like lifted, but the flap is not freed up, apically, coronally, or laterally, from an area adjacent to the recipient site to a new location relative to the site they occupied before the procedure. Like repositioned flaps, most position flaps heal by repair. In position flap procedures, the flap's vascular supply is maintained, unlike free gingival grafts. And we will stop there. We'll go next to types of position flaps.